Hi, my name is Jeremi Mountjoy. I'm an anesthesiologist at Massachusetts General Hospital, and I spend most of my clinical time in among a few services, particularly the thoracic OB and vascular services. I'm going to present to you a talk today about the management of patients with anterior mediastinal masses. I have no financial conflicts of interest. So, our talk today is about anterior mediastinal masses, and I'm sure some of you have seen CT scans like this on your patients. You can see I've sort of outlined an anterior mediastinal mass in a patient of mine, and the objectives of the talk today will be to look at the incidence and main types of anterior mediastinal masses. We're going to make sure that you have an approach to the preoperative assessment and constructing an anesthesia plan for patients with anterior mediastinal masses. We're going to appreciate the cardiorespiratory compromise that can occur in anterior mediastinal masses, and you're going to understand the anesthetic considerations for these patients, whether they're undergoing biopsy or removal. So I'd like to start with a case, and we're just going to follow this case all the way through the talk. And this is a case of a patient of mine from several years ago. This patient was a 24-year-old man, worked as a firefighter. He complained that his legs were getting heavy when he was standing up. On history, he had about a 6-week history of a dry cough. It was worse when he laid flat. He lost about 12 pounds of weight. This was a big, greater than 100 kilos, 6'3" gentleman. Lost about 12 pounds. And his wife said that his face looked puffy. He'd also experienced tachycardia. The patient was suffering from orthopnea and positional distress, and was getting worse over the course of the day in hospital. As an outpatient, he had been seen by a PCP and prescribed some propranolol to help with his tachycardia. That did not fix the problem. And at 9 p.m. in the operating room, he was added on as his symptoms were worsening throughout the day. I'd like to credit DT Balakrishna, who's an anesthesiologist and critical care physician at Vanderbilt. We did this case together when she was a senior resident, and she helped with the write-up of the case initially when we presented it at ASA. It was a medically complicated case. But first, let's talk about the types of anterior mediastinal masses. The incidence can be somewhat difficult to determine. It's not entirely clear what qualifies as an anterior mediastinal mass, and what I mean by that is if a patient has a lymphoma that presents, for example, as primarily neck lymph nodes with perhaps some mediastinal nodes as well, that patient will probably just go and have a lymph node biopsy of the neck and receive treatment. It may never come to be classified as an anterior mediastinal mass. Same can be true for thyroid tumors, which can present in the neck or start to encroach in the mediastinum. And so counting these is somewhat difficult, but as close as we can determine, the incidence seems to be that these are primarily thymic malignancies, about a third of the time. Lymphoma is also common. Thyroid and other endocrine tumors comes in next, as well as the benign teratomas. And then, of course, there's the malignant germ cell tumors like seminoma and non-seminoma germ cell tumors. And there are some benign thymic lesions as well. These are rough overall incidences. The types of anterior mediastinal mass do vary with age. So in adults who are greater than 40 years of age, there's thymoma and thyroid masses, which constitute about 2/3 of them. In terms of coming for biopsy, we often don't see the thyroid masses because these are typically diagnosed with imaging alone, and then they proceed to resection. So we may see them coming for resection. These are often accomplished through the neck, although sometimes sternotomy is required. Teratoma and germ cell tumors are also are the next most common, as well as lymphoma. When we look at patients who are younger than 40 years of age, what you're going to see is that the diagnosis depends heavily on gender. So in females less than 40, lymphomas are the most common tumor type, then thymoma, teratoma, and rarely germ cell tumors in females. It's a little bit different in men. Men aged 10 to 39, germ cell tumors are the most common diagnosis. That would be the seminoma, non-seminoma germ cell tumor. Lymphomas, thymomas, teratomas complete the list. So our patient is a 25-year-old man, and in his case, there was suspicion for lymphoma due to the rapid onset of symptoms. So lymphoma, the pathological diagnosis, requires a fairly large amount of tissue in order to look at the tissue architecture to determine the type of lymphoma, which dictates the treatment. And fine needle aspiration of flow cytometry are also important. So that's why these patients benefit from biopsy. That's why they come to surgery, because the differentiation will determine the treatment and can benefit the patient's long-term survival. So this is why it's worth the effort to anesthetize these patients. So mediastinal masses present with a variety of signs and symptoms, and they can be broadly classified into two areas. One is localizing or sort of mass effects. And these can include things such as cough, dyspnea, hemoptysis, dysphagia, chest pain, hoarseness, all effects of the tumor in the chest, or perhaps even impinging upon the airway. SVC syndrome is also common and frequently complicates anesthetic management. Symptoms of swelling, plethora of the head and the upper extremities need to be looked out for on history and physical examination. Cardiac tamponade or compression is also a risk. The perineoplastic syndrome is the most commonly seen one, is myasthenia gravis, which we're all familiar with as anesthesiologists. And it also complicates management. Other so-called B symptoms of malignancy, including anemia, fatigue, fever, night sweats, chills, and weight loss, are commonly seen. And in our case, our patient had cough, dyspnea, SVC syndrome. Clearly, his wife said he was becoming unrecognizable. Swollen, plethoric face had. Our patient did have some cardiac tamponade. I'll get to that later. It was seen on echo, evidence of ventricular compression. The perineoplastic syndromes and B symptoms, the patient had fatigue, night sweats, as well as the weight loss, which I mentioned earlier. So clearly the case we're following is true to type here. A lot of the localizing symptoms and certainly some of the B symptoms as well. One of the keys with thoracic anesthesia in general that I'm always trying to impart on the residents that I work with is the importance of imaging. The disease process going on with anterior mediastinal masses and impinging on all the structures that we're relying on to keep the patient alive, all the cardiorespiratory structures. So reviewing the CT scan yourself to understand what you're dealing with and becoming familiar with reviewing those scans is very important. The chest x-ray is also important to review, of course. Airway compression, you really want to take a look at the degree and the location when you're planning your airway management. Is this something that you're going to be able to bypass? What size tube would you choose? And what is your backup plan should you not be able to pass the endotracheal tube you're planning? Certainly with severe compression, this is where you start to think about having a rigid bronchoscope set up in the room and someone who knows how to use it there and ready at induction. Cardiac and SVC compression are also very important to identify and will complicate your anesthesia management. Pleural effusions and postoperative pneumonias are important, as well as just looking at the echocardiogram. Certainly, if the patient has any exertional dyspnea, an echocardiogram is important. PFTs, this is a question that comes up quite a bit. Flow volume loops, forced vital capacity, supine and upright, spirometry. There's been a lot made of those. Many residents will spontaneously cite those factors. It's in textbooks. These factors are neither sensitive nor specific, and this was written about as a persistent myth some time ago now, although it still persists. And it's funny how sticky that perception is being. Patients, these cannot be relied upon for decision making based on the evidence that we currently have. So when you have a patient, you need to formulate a plan, and when formulating a plan, it's important to consider all of these issues, and we're going to go through them sort of one by one. Firstly, is the patient able to undergo the procedure with an anesthetic, and do they even require one? So when determining if the patient's safe, I think the single most commonly relied upon finding is positional symptoms. So is the patient able to lie flat? Sometimes you get a little clue that the CT has been done supine, although a modern CT scanner can do the scan in about 30 seconds, so that's not a huge amount of time. Although being able to lie flat for even a short period can be important. Can you lay the patient back to at least 45 degrees? That's certainly something. Can they be comfortable there? And then another issue to consider is, do they have position relief? So are they better on one side than another? And would you consider inducing anesthesia lateral? The other piece that's often cited is having a stretcher in the room so that the patient can be flipped to prone, if that provides relief from the mediastinal compression. And ultimately, this does come down to a somewhat subjective decision, whether or not you believe the patient to be safe for general anesthesia based on experience. Generally, the way I practice, if the patient can lie flat without a problem, then I am very reassured about inducing general anesthesia. If the patient struggles to lie flat or can only lie semi-recumbent, then I consider careful induction of general anesthesia. And if they're unable to lie flat or completely in distress with any suggestion of it, then we consider other options. We're going to get to those. So certainly max sedation for biopsy can be a good option for some patients for some procedures. Obviously not for a large resection, and obviously not for a patient who's extremely anxious. Positioning can be a problem. The patient may not want to tolerate the positioning, and that could be for patient factors, but it could also be for physiologic factors to the tumor that they just won't tolerate laying flat. So anesthetizing laying flat with caution. If the patient is not safe undergoing general anesthesia, ECMO or cardiopulmonary bypass is a very rarely employed option, but it is something that is possible. Certainly, it's not something to plan to crash onto or to have on standby. That doesn't really provide a reasonable pathway to rescue the patient in a timely fashion. Again, the ability to lie flat is the critical point for risk stratification. In talking to thoracic anesthesiologists at my center and many other centers, this is the number one critical stratifying point. So is the patient safe for induction? The next issue to address is whether or not to have the patient breathe spontaneously if you do induce general anesthesia, and why that's important. So severe airway compromise does have an extremely low incidence. This is a CT scan from my patient. As you can see, there's a significant amount of compression of the trachea in the upper mediastinum. The question is, can you intubate past this obstruction, and can you ventilate after induction and paralysis? And those are the things you really need to know. There's the trachea. One thing I often hear is if you induce general anesthesia and paralysis, the airway may collapse. Collapsing sounds so dramatic, it has a certain ring to it, and people seem especially drawn to this. People who perhaps haven't done a lot or haven't done a lot of these cases are very leery of this. It's been a teaching for a long time, and for some reason it's a pretty sticky one. But what is the evidence for this? As I was preparing this talk, I stumbled on this great study. It was in anesthesiology in January of this year. One of my Harvard colleagues was the first author, Philip Hartigan. 17 patients were prospectively studied with large mediastinal masses. They were intubated awake, and fiber optic bronchoscopy was performed. Measurements of the airway were taken while the patient was awake and breathing spontaneously, after general anesthesia was induced, and after paralysis was given. And what they found in these 17 patients is that there wasn't any significant change in the diameter of the airway with the induction of general anesthesia or with the administration of paralysis. This makes a lot of sense to me. When the airway collapsing is invoked, people often suggest there's various muscles stenting open airways, and I don't know which muscles those are. I've never really been able to get a good answer on that. I think there is thought that the negative pressure of breathing is holding open the airway, and there may well be some small amount of change, but in the adult airway, where the airway is relatively rigid, there is not a big change in the airway diameter with induction based on the evidence that we have. It's not to say that it's impossible that a very compromised airway could prove impossible to ventilate after induction, but it's relatively reassuring that the airway is not going to up and collapse on induction. And based on my clinical experience and my patient care, is that the airway is typically not the issue with induction of spontaneous ventilation. And in fact, what is more of a problem is the issues of preload, tamponade, and right heart compression. So the real reason, in my experience, this is also from the case that we're discussing, there's a significant amount of pericardial fluid causing tamponade. The real reason that we want to maintain spontaneous ventilation is for the preload of the heart. I wonder if perhaps this whole idea of the airway collapsing is so sticky because, when a patient is induced and the airway is thought to have collapsed, rigid bronchoscopy is going on, the circulation is collapsed, you're trying to support the patient. It's really hard to sort out what's going on in that kind of a fog of war situation. And I think it's important to really keep in the front of your mind that the main reason that spontaneous breathing can be an important piece of the puzzle is for the cardiovascular compromise, not the respiratory compromise. Securing the airway is separate. Now, sometimes the cardiovascular issues can interact with the airway issues, like with an SVC syndrome. But for the most part, spontaneous ventilation, in my practice, is a consideration of the cardiac status of the patient. And the positive pressure here is not really the issue. And again, pediatric is a totally different animal, and I will defer to my pediatric anesthesia colleagues on that one. Very different airway. Next question to answer is the maintenance of spontaneous breathing, and how you're going to accomplish that. There's a couple of camps. One is inhalational induction, and some will advocate for the careful titration of IV agents. Maybe it's because I'm at MGH and we have the ether dome and a long history of inhaled anesthesia. But I am partial to a brief down in these cases. I find it's very easily titratable. You have fewer things going on, so you can pay attention to the airway. And as the patient starts to obstruct, they automatically slow down their induction. Some are very convinced that titration of IV medications is a much safer method. I think the more important question is which one are you best at, and which one do you feel most comfortable with? I know for me, it is certainly the inhalational induction in these patients. And so when we're formulating a plan, the next thing we need to think about is our approach to invasive monitoring and access. I think in a patient where you have any concern for positional symptoms or cardiac compression, tamponade, SVC syndrome, pre-induction arterial catheter is kind of a no-brainer. We place these with a very low threshold. As you can see in the scan from our 25-year-old patient, there is complete obstruction of the superior vena cava. And so this patient is going to require a lower extremity IV. And we did indeed place a 16 gauge in the saphenous vein. I have had patients with this present with ports and come to the OR with a port which also was not working properly with SVC obstruction. It's just important to remember that, you know, upper extremity, upper body central lines also are not going to function. You need a lower extremity IV or a femoral central line in patients with severe SVC syndrome like this. If you don't place a lower extremity, you're going to have slow flow in your IV, and you're going to have very slow onset of drugs. So, as you're formulating the plan, let's just think about our case and how we formulated our plan. So this 25-year-old patient, is he safe for induction? We thought he was. He could lay back about 45 degrees. He wasn't super happy doing that, but he could stay laid back 45 degrees somewhat indefinitely, and that was very reassuring to us. We were worried, and we did not want to risk paralysis in this patient. We thought that he was kind of on the brink, and we wanted to maintain spontaneous breathing in him. I picked an inhalational induction for the reason I mentioned earlier, because I find it to be easily titratable, and I like that. I like that the patient's minute volume dictates the rate of their induction. So as long as they're breathing well, they can induce fairly quickly. If they do start to slow down, it's easy to slow down the induction. Let that sevoflurane redistribute through their body, and they'll naturally lighten back up. When I do an inhalational induction, one of the cons is that you often have to do a very deep inhalational induction to be able to intubate the patient safely. I get around that typically by doing a fiber optic intubation, which is less stimulating, and I will spray the cords with lidocaine. So typically I don't have to go much below 1 MAC. And this was a young man, so we did go to about 1.5 MAC in this patient, but typically a flexible intubation, lidocaine on the cord so that I can avoid paralysis and maintain spontaneous breathing. In terms of invasive monitoring and access, as I said, there was a preoperative arterial line and a lower extremity IV. So here's an anesthetic record of our patient's anesthetic. As you can see, I want to point out a couple of things. There was quite a lot of norepinephrine used in this case to maintain hemodynamic stability. There are two important points. One right here, we had a significant decrease in blood pressure right before we secured the airway. And at that point, we attempted to gradually take over positive pressure ventilation by assisting the patient's breathing with the bag and the anesthesia machine and the face mask. And as you can see, that had a significant deleterious effect on the patient's blood pressure. So we backed away from that approach and maintained the patient breathing spontaneously, sprayed the cords, and secured the airway rather than paralyzed. After the patient was safely intubated, prepped and draped, we did attempt to lay the patient back a little bit further, and that was not well tolerated by the patient either, despite significant norepinephrine there. So we again returned the patient to that semi-recumbent position. And so for this case, we did go ahead and, despite the high pressure requirement, we did proceed towards extubation in the OR since the patient required no circulatory support pre-op. We hypothesized that returning him to his preoperative state after his biopsy, he would do better. And in fact, on extubation, sitting upright, the pressor requirement was entirely gone. Because of his accelerating condition and his postoperative state, he was recovered in an intensive care unit. The patient was diagnosed with a diffuse large B-cell lymphoma. He responded really well to steroid therapy. I went and saw him a couple of days later, and he looked 10 years younger. The SVC syndrome had somewhat resolved, the plethora was gone, and he was feeling much better. Greater than 2 years later, after his treatment for lymphoma, he had no detectable disease and was told that he had survival comparable to age-matched peers by his oncology team. So just to finish, I'd like to mention a few take-home points. When assessing these patients, number one, you want to determine, can the patient lie flat and for how long? This is critical in determining the approach, whether or not this is a patient who can undergo IV induction with paralysis, whether this is a patient who needs a titrated induction with spontaneous breathing. Look at the CT scan. That's probably the second most important piece of information, to look at the magnitude of the tumor and the various mass effects it's having locally. Considering sedation or extracorporeal support in very rare circumstances, but important circumstances. Semi-recumbent positioning is a good thing not to forget. I've certainly seen patients who weren't comfortable upright, induced and laid flat, and then all of a sudden we're going to battle with the blood pressure, and often returning the patient to the semi-recumbent position can be very helpful. Spontaneous ventilation or not is a very important decision point, mostly for the cardiovascular effects. However, it can have a role in airway considerations as well, but the adult airway is unlikely to change that much under anesthesia. And then beware SVC syndrome. If you've induced a patient and you're wondering why your drugs aren't working very quickly, this could well be the cause. It's certainly easy to get caught out not attending to that, or relying on a PICC line or a port that's in place and being used on the floor, but just not providing the rapid response to medications that we require in the operating room. Thank you very much for your attention today. I hope you're enjoying the course, and I hope we hope to have you back here in Boston for spring sometime in the near future. Thank you.